Good afternoon or evening. Thank you for joining us today. We will begin shortly. Please follow us on Instagram to hear of future events. Thank you.
Hello and welcome. My name is Leandra Sims. I am the Memory Care Program Manager at the Kensington Sierra Madre, and I am so thrilled that we are all here this afternoon. I am so grateful to work at the Kensington with dedicated memory care in all of our communities. I feel we are leaders and innovators in caring for those with dementia. Kensington Senior Living has 7 unique communities, 4 located in Virginia, Maryland, and New York, and 3 sister communities located in California. Kensington is truly privileged to support care partners in care from coast to coast. Kensington Senior Living focuses on relationship-based care built on the foundation of our promise to love and care for your family as we do our own. It is programs such as Care, Cure, Prevent that are so important for those of us walking through a dementia journey to hear from expert professionals on keeping us current on the latest advances in care, research, and prevention of Alzheimer's and other dementias. It is my pleasure to introduce Lauren Miller Rogen, moderator of today's presentation. Lauren Miller Rogen is a screenwriter, director, producer, and philanthropist whose life has been touched many times over by Alzheimer's. In 2012, when Lauren's mother was diagnosed with early onset Alzheimer's disease at just 55 years old, Lauren, still in her 20s, co-founded HFC to activate the next generation of Alzheimer's advocates. Since then, Lauren and the HFC team has brought significant awareness to Alzheimer's, raising millions of dollars to award free, quality, and home care to families in need of respite and support, all while using humor and hope to engage people. Her dedication to sharing her personal story and using humor as a form of advocacy has left an indelible impact on Alzheimer's space. Since 2013, Lauren has served as the Alzheimer's patient advocate on the board of California's Institute of Regenerative Medicine, CIRM. She also sits on the California Alzheimer's Task Force and the steering committee of the Milken Institute's Alliance to Improve Dementia Care. In 2012, Lauren starred in, co-wrote, and produced the film For a Good Time Call, which premiered at the 2012 Sundance Film Festival. She made her feature-length directorial debut in 2018 with the dramedy Like Father, a film she wrote and which starred Kristen Bell and Kelsey Grammer. If there's one thing Lauren wants to remember, it's that Alzheimer's doesn't have to be as sad or scary when you're fighting against it. You can come to an HFC event and have fun, but also do something for Alzheimer's. Welcome, Lauren, and we are so excited to have you here today.
Thank you so much for that lovely introduction and all that good information about me. I'm so excited to be here. I'm so appreciative to be among these amazing panelists and all of you who've joined us today. This is the second year in a row that we're doing this, and I'm just so thrilled with all the incredible information that is shared during this conversation, and we're going to do so much great sharing today. I'm also thrilled that we're having this conversation during National Family Caregivers Month, which November is. Caring for caregivers is hugely important to us at HFC. We have support groups 7 days a week. We award grants every month that send professional caregivers into the homes of families who are struggling. We teach everyone how to care for their brains, because while we may not be able to cure this disease yet, we can care for our brains and decrease our risk and potentially prevent it. So I don't want to take up any more time talking about me, because this is about you and your questions, which we have ready to go. Thank you for submitting them in this registration process that you all went through. A few little housekeeping things, just so you know, everyone's going to get a copy of today's webinar to share with your friends and your family. So you'll get all this information afterwards. So, you can write it down if you want, but you don't need to, because you're going to get it. And then also, again, I said we have all your questions, but if time permits, we'll do more Q&A at the end. So we'll see how it goes time-wise. Now I am going to introduce our panelists. They're going to each share a bit about their background. They are very impressive, as you can imagine. I'm going to have each of them turn on their cameras as I read their names. So we have Dr. Shaw, Dr. Kremen, Dr. Parent, Dr. Winden, and Dr. Melina Henry. Hi, everyone. We're all on, right? Did Dr. Kremen come on? There she is. Okay, great. Everyone, I see everyone. Okay, great. So why don't, let's have each of you introduce yourselves. Let's start with Dr. Shaw. Give us a little, overview about yourself, and then pass it off to who's ever in the square next to you. Pass it off to them.
All right. My name is Sharon Shaw. I work at Stanford University. I'm a trained behavioral neurologist. In my clinic, I see patients with Alzheimer's disease and other related dementias. When I'm not in clinic, I spend my time researching clinical trials and finding the next cure for Alzheimer's and other related dementias. So Dr. Perron, please maybe introduce yourself.
I'm at UCLA. I'm an assistant faculty here. I enjoy working with patients with memory problems, and I'm a neurobehavior specialist. I've been doing it for a couple of years and finished the fellowship not too long ago. I just really enjoy trying to help patients and address their problems. Pass it on to Dr. Kremens.
Thank you very much. So my name is Dr. Kremen, and I'm the director of behavioral neurology program at Cedars Sinai, where I see patients with a variety of concerns, whether that's Alzheimer's or primary progressive aphasia or FTD or dementia with Lewy bodies. And also, like Dr. Shaw, also see patients for clinical trials and other observational studies that we're trying to basically understand the underpinnings of many of these neurodegenerative diseases. And so now I will pass this off to Dr. Winden.
Wonderful to meet you all. My name is Dr. Charles Winden. I'm one of the assistant professors here at the UCSF Memory and Aging Center. I'm also a behavioral neurologist and really wear 3 hats in my role. So I participate in clinical care of individuals with Alzheimer's and dementia and other neurodegenerative conditions. I participate largely in biomarker research, trying to understand better tests for earlier diagnosis and more accurate diagnosis. And then I'm heavily invested in community outreach and engagement with communities. And with that, I'll pass it on to Dr. Melina Henry.
Dr. Winden. I am Doris Melina Henry. It's a pleasure to be here. I'm an assistant professor at USC's, our University of Southern California's Alzheimer's Therapeutic Research Institute. I am a trained neurobiologist, which means that I did a lot of basic science research, and I'm now working mostly in clinical trials, particularly within the areas of recruitment and retention science. So better understanding how we can best engage individuals to participate, so we have representative trials that can allow us to best understand how investigational treatments will serve the population that best needs them, that most needs them.
Amazing, impressive, right? I know, I told you it was amazing. So, okay, let's just dive right in. Everyone's prepped. We'll keep it kind of game show style, as we call it. I think Dr. Shaw, we're going to come to you first. The difference between dementia and Alzheimer's. How does one determine if they're experiencing normal memory loss versus dementia or Alzheimer's?
Yeah, I get this question a lot in my clinic about what's the difference. I think what I usually start off with is defining the term. What does dementia mean? And it's an umbrella term. It really means that there is a cognitive problem, whether it's memory, language, navigation, or other, where it's now causing impairment in our functional independence. What does that mean? The ability to manage your finances, take your medications, do your shopping, your cooking, your laundry, basically running your household. And it's a progressive disorder as of right now. Alzheimer's disease is the most common type of dementia, and so we often conflate the two or use them synonymously. But Alzheimer's disease is a type of dementia that has specific symptoms and pathology, but there are other kinds of dementia: vascular dementia, Lewy body dementia, Parkinson's disease dementia, frontotemporal dementia. So a number of other dementias that are in that umbrella. So I'll pause there.
Great. Does anyone have anything to add to that before we go on to the next one? Cool. Dr. Kremen, coming to you. Tell us, is Alzheimer's a genetic disease? Is there a difference, and the difference between early onset and we'll call it normal Alzheimer's? I don't think there's anything normal about Alzheimer's, but you know what we mean.
Right. Right. So Alzheimer's can be hereditary, but it doesn't have to be. So many times the number one risk factor for developing Alzheimer's disease is actually probably not necessarily genetic, but it's just aging, that we're all at risk for Alzheimer's disease because we are all aging. But aside from that, we have various types of genetics that can affect people and have them either have an increased risk for developing Alzheimer's disease or actually inheriting a gene where if they get this gene, they will definitely develop Alzheimer's disease. So from the most common thing is that it happens as we get older. It's just sporadic and it happens. But we do see it running in families, right? A lot of times people come to our clinic and they say, my mom had it. Now I'm worried that maybe I have it because I'm starting to have memory problems. And so we know that there is an increased risk that if you have a direct relative, say a mother or a father, then you do have an increased risk of developing Alzheimer's disease, maybe by 1.5 times. But there's no specific gene necessarily there's a lot of different genes that are modifying and causing people to have dementia, especially due to Alzheimer's. But the most common gene that you might hear talked about is ApoE, the ApoE gene. And this is a gene that actually shuttles around cholesterol, but also is associated with increased risk for Alzheimer's disease. And some people inherit a specific form called 4. It's very boring, but if you think about ice cream, you could have chocolate, vanilla, and strawberry, and you could get one ice cream cone from your mom and one from your dad. So instead of calling it chocolate, vanilla, strawberry, we just call it 2, 3, 4. So you can get 1, 2, and a 4, or a 3 and a 3. So people who inherit 4, the type 4, have an increased risk of developing Alzheimer's disease. So increased risk by 4 times if you get 1 copy, and by 12 times if you get 2 copies. But even so, that doesn't mean you'll definitely get Alzheimer's. Lastly, before I wrap up, because I've just said a lot, there are a small number of people, less than 1% of all people who get Alzheimer's disease, who actually have a gene where it's autosomal dominant, where we actually know that they will get this disease because they have a disorder that's on various genes that have been identified. There's been 3, presenilin 1, presenilin 2, and the amyloid precursor protein gene. But this runs in families, and this is very much attached to early onset. We're talking people who have problems in their 20s, their 30s, their 40s, and it's affecting multiple people at each generation. So we know that there are people, say big families in Colombia, big families in Mexico and other places that are being followed in research now, where this is a totally different thing. Most people do not have that kind of Alzheimer's disease. And I'll stop there because I just said a lot.
But you said it so well and very succinctly, so it was really helpful. Does anyone want to add to that before we move on to the next one? Obviously, it's you probably honestly answer that question for hours and days, but.
Can I just add, Dr. Kremen did a great job. What we're learning more now is what's fascinating about this ApoE4 gene. People get very worried if they find out they have a copy because they submitted their ancestry or something like that. And it's different for different people, meaning that we see in women who have ApoE4, the risk is greater than in men. We also see in certain racial ethnic backgrounds, the risk is greater or less. So in Asians, it's rarer, or East Asians, to have ApoE4, but the risk is greater if you have it. In African Americans, the prevalence is higher, but then the risk is less than in white Caucasians. So we're just learning more and more about the genes, and there's so much more beyond the genetics for the risk for developing Alzheimer's disease.
And not to take this conversation in another direction, we won't, we'll get right back on track, but to say that if you do learn these things and you understand your genetics, there are, obviously we don't know for sure what can prevent it, but there are modifying behaviors and things you can do. So that is something I think important to be said. Thank you. That is, I think honestly, so many people ask me the genetic question all the time, and I think that's really top of people's minds. So, all right, let's go to another big one. Dr. Winden, tell us, how available are blood tests for Alzheimer's disease? Can I see my regular doctor have these tests performed?
Sure. So it's a really important question, and it ties actually a little bit into, and we can maybe bring it in, the idea of should I get tested from a genetic standpoint, actually. So when we think about testing for Alzheimer's disease, one of the kind of newest diagnostic tests that we have are plasma-based tests, meaning blood tests. And so we can look for different pathological hallmarks of Alzheimer's disease in the blood. Pathological hallmarks is just a fancy term for the different proteins that build up in the brain that are kind of signature of Alzheimer's. These are the amyloid and tau proteins that many of us have heard before. And so currently there actually are tests that you can have performed in the clinic that are blood tests for amyloid protein specifically. There's one offered by a group called C2N Diagnostics. There's another that actually offered by Quest Diagnostics. The problem with these blood tests is that they're not yet FDA approved. They're CLIA approved, which is a little bit different. CLIA stands for Clinical Laboratory Improvement Amendment. It's kind of like a different regulatory body. But per the research that has come out for both of the tests, they seem to be relatively accurate in terms of identifying brain amyloid plaque status when you do a couple of additional tests to kind of demonstrate or prove that the pathology is actually present. There's some problems though with blood tests in actuality though, in that if you look at the recommendations currently, specifically by the Alzheimer's Association, they're for use in a very narrow population for a very specific set of criteria. So getting kind of right to the question about, can I go to my primary care doctor and get these tests? The Alzheimer's Association actually recommends that you do not have these tests performed in a primary care setting because we're still learning about them, and you also need a little bit of expertise with regards to interpretation. Can you have them performed in an actual memory clinic setting? You can. They're typically, again, recommended only for individuals who are symptomatic, meaning actively having memory thinking problems. And it is actually recommended that an additional diagnostic test be done to confirm the results of the blood test, either a CSF, a cerebrospinal fluid study, or a PET scan of some sort. So a lot of advancement has been made in the field of really blood-based biomarkers for Alzheimer's disease. We're not quite at an area though where they're widely available in your primary care doctor's office and super, and we don't fully understand all the intricacies of them, I would say.
Yeah. I think a lot of people really, they go to see their primary care physician and things become a lot more confusing instead of the opposite. And I think that hopefully as time goes on, it'll become, all primary care doctors will become more well-versed in those types of things, but it is important, you're right, to see the right person, because can create confusion, that's for sure. Okay, Dr. Molina Henry, tell us clinical trials, what's going on as far as prevention goes? What are the best preventative measures to do if Alzheimer's, runs in your family, if you do have one of these, genes that potentially increases your risk? What's happening in the prevention world there?
Thanks, Lauren. And I think this is it's a great question in light of the previous question as well, because clinical trials, particularly in the prevention world, are using blood tests for that specific purpose. They're using them to identify individuals that might benefit from a drug that is investigational at the time. And so I just briefly, to give a broad overview, when we think of clinical trials, and this is oftentimes more within the field, we think of trials that are very lifestyle based. And then we also think of pharmaceutical trials. And what's exciting about these lifestyle-based trials is that they're aimed at evaluating what are the existing recommendations and seeing whether those recommendations can actually prevent, delay, or delay and prevent Alzheimer's disease from presenting itself, or particularly the symptoms of Alzheimer's disease from presenting themselves. On the other side, we have pharmaceutical trials. And I think this is one of the most recent exciting shifts that has happened in the Alzheimer's field, that are trials that are pharmaceutical, that are aimed at prevention. So identifying individuals that are going to be at high risk for developing symptoms of Alzheimer's disease later in life, but treating them with these investigational drugs early on. We know that some of these those proteins that are related to Alzheimer's disease begin to show up in the brain of individuals that develop Alzheimer's disease about 20 years before those symptoms actually occur. So that gives us this phenomenal time period where once individuals are identified to be at high risk by virtue of those proteins, we can begin to treat and prevent. And so the hope is that we begin to identify during that time period ways in which we can delay the presentation of symptoms, particularly memory loss, among all the other things that have been mentioned before, or even just change the course of the disease, hopefully in the future. One of those trials, and I'm happy to share a name, is the AHEAD study, which was one that actually focuses on looking at individuals 55 and older and evaluating whether they have enough levels of amyloid, where they can participate in the trial and see if this is an investigational treatment that could work to delay the symptoms of Alzheimer's disease.
Amazing. If I can, I'll just do a quick plug for HFC. Again, as I mentioned, we really prioritize teaching people how to care for their brains. So if you're interested in learning more, come to wearehfc.com, sign up. We'll give you lots of good information. Commercial over. Back to the questions. So let's shift to people who are living with the disease. Dr. Perrin, so I'm going to ask you, how do you recommend treating behavioral issues that are related to dementia? The question was asked, do I call 911 if the behavior is out of control?
Well, so first you need to address what is the underlying cause. If it's related to something that could be associated with pain or urinary tract infection, investigating that. Sometimes it's the way that people are communicating in the household. So it can be frustrating when someone's repeating something over and over again, and you're trying to balance a lot of things in your daily life. So it might require working with a special geriatric therapist that can work to address issues in communication. Sometimes the patients have hallucinations and delusions, either associated with Alzheimer's or Lewy body dementia or another dementia. It might be that memory medications could benefit that. It would be trying to address it through, first, if you can manage things through non-pharmacological means, that would be ideal. We have some caregiver videos on the Easton Center website that help to, when dealing with hallucinations, or if someone's not taking their medication, they're very nice videos that go through it. They're 3 to 5 minute segments that can help. Dr. Shari, he's from Ohio State, he did a presentation where he showed that if you ask patients to help do things, if you say, can you show me how to fold the laundry or do activities to keep them preoccupied, because it might be due to lack of stimulus that they're getting agitated. So trying to address it that way, and then if needed, there are additional medications, either SSRIs or antipsychotics that could be used if other means cannot be able to manage the behavioral issues. If things are out of control, certain situations that might require calling 911. So if it's out of control, you can't redirect the patient. It's a danger either to the patient or the people around you, then it might be needed to call 911. Not sure if anyone else has anything.
Does anyone have anything else to add to that? It's such a, anyone who's cared for someone with dementia is very familiar with this situation. And I think, obviously the thing is, anyone who has dementia is different from anyone else who has dementia or Alzheimer's. So there really is no one way to really answer that question. I'll just add a personal, which is, my mom had a lot of behavior things and they were due to UTIs, which we didn't know. And that is a very common one. I'm so glad you brought that up, because I think that people are not aware that that's a very common thing and can cause behavior issues. And once it's treated, it can really help. So that is a tough one. All right, Dr. Kremen, someone receives a diagnosis of MCI, mild cognitive impairment. What are the next steps? What do they do? Question, how long does one live with dementia or Alzheimer's? That's such an impossible question to answer, but someone gets the diagnosis, what's next?
Great. Yeah. So first, maybe we should just define what mild cognitive impairment is so that everybody's on the same page. So mild cognitive impairment basically means that you have a cognitive concern, usually, oftentimes it's memory. So I have a memory concern. I go to the doctor. And the person who comes with me also thinks, yes, you know, I have a memory issue that's changed from baseline. And then the doctor tests me and they see on testing that there is truly, you know, a documented objective change in memory or other areas of cognition, but level of function, you know, doing activities of daily living, like being able to do errands, write a checkbook, take care of medicine, go to the grocery store, remember to take a shower, brush teeth, all those kinds of things are okay. So there's a cognitive change, there's a cognitive decline, but not a functional decline. And so that means mild cognitive impairment, or MCI, which we differentiate from what Dr. Shah said before, which is dementia. Dementia, again, is that umbrella term of cognitive decline accompanied by functional decline. So mild cognitive impairment is kind of in between normal and dementia. You've got this area in the middle. So if you get a diagnosis of mild cognitive impairment, what does that really mean? Well, mild cognitive impairment could be due to so many things, right? It could be due to depression. It could be due to obstructive sleep apnea. If you're not sleeping well at night and not oxygenating well at night, then it can cause memory problems. You could have mild cognitive impairment due to a UTI. You could have mild cognitive impairment due to vascular disease. There's many reasons, and it doesn't have to be due to an underlying disease like Alzheimer's disease. So that's the first thing to know, that mild cognitive impairment is really just a description. It's not really a diagnosis the way getting a diagnosis of Alzheimer's disease or Parkinson's disease or hypertension is. It's not that kind of thing. That said, if you get a diagnosis of mild cognitive impairment, usually then we try to figure out, well, what is the mild cognitive impairment due to? Because if we can fix it, that's the next step, right? The next step is fix what you can fix. So you'll find that in a memory specialist's office or a geriatrician's office, they're going to look for reversible causes of cognitive problems. Check thyroid, check vitamin B12, you know, check mood, anxiety, make sure that you don't have sleep apnea, you know, anything that, or medications. Sometimes medications can cause cognitive difficulties. So we're really going to try to check all these different things before we say, oh, it's definitely due to a neurodegenerative disease. But we also are looking for neurodegenerative disease as well. And so that might require in mild cognitive impairment that you go on to get a brain MRI, right? To make sure that you don't have strokes or shrinkage of the brain in areas which could point us towards something neurodegenerative, a disease. And sometimes people even go on to get a PET scan, which looks at activity of the brain, or they'll go on to get further more formal cognitive testing, neuropsych testing that might take 2 or 3 hours to really try to delineate what are the cognitive changes that somebody's having, because we can tell from that pattern what that might be due to, because we know what Alzheimer's looks like, we know what depression looks like, we know what these different entities look like, and that can help steer us towards a diagnosis. That said, once you get a diagnosis, and if it does turn out to be Alzheimer's disease, then the question is, what do you do? And you know, it used to be, honestly, with mild cognitive impairment, that we sat with it and people just kind of followed along, and it was sort of this nebulous area. And I would still say it is nebulous in that you're in this nether region where you're not normal and you don't have dementia. But there's a lot now that, at least at the major academic centers, we really don't sit around with MCI and say, well, we'll just kind of wait and see what happens. For us, I think we really feel like we do push to try to understand whether it's due to Alzheimer's disease or not, whether that means getting a spinal fluid test to look at the proteins in the spinal fluid to see if there is Alzheimer's disease or not. We also will sometimes push for a PET scan if we think we need it, again, because we really want to know if somebody does have Alzheimer's disease or not, because we know that that's an opportunity, a prime opportunity actually, to jump into a clinical trial. You know, that's one of the best things. And also it's a really great time to be saying, look, we got to make changes, got to exercise, eat right, make sure that you're sleeping okay, make sure that we're addressing mental health and all these things. And eventually the hope is there are going to be medications that we could start. Sometimes people will start medications that you may have heard of, such as Aricept, in mild cognitive impairment. The American Academy of Neurology does not recommend that, I think mostly because they're concerned that the moment somebody gets a diagnosis of mild cognitive impairment, everybody's going to be put on this drug, and that's not necessarily what they should be doing. Again, you don't treat obstructive sleep apnea with a drug for Alzheimer's, and they don't want that to happen. But you will see sometimes in specialty clinics or other places that if we really have a hunch that it might be due to Alzheimer's disease. Sometimes people get started on that kind of medication, although I'm not going to say it is not the standard recommendation. The other question that you had is, how long does somebody live with dementia, and how long does Alzheimer's last? And honestly, everybody takes their own path through this disease. Sometimes we say we look backwards to see the future. So some people, particularly younger onset, seems to go faster than people who are of older age. You know, if you look at, like, say, the Alzheimer's Association website, you may see that the average duration is about 10 years, but you'll also see that it could last for 20 years. So it really just depends for every person. And I'll stop there because I just said a lot.
A lot of important information, though. Sort of building on that, we'll go to Dr. Shah and Dr. Melina Henry. Let's talk about lecanemab. Why don't they give them names we can pronounce? And what this means for Alzheimer's treatment and research, and also other new developments in the AD area. And also, does plasma measure to detect biomarkers? Very scientific question.
Dr. Melina Henry, do you want to take that, or do you want me to take it first?
I can start and we can tag team.
Yeah, let's do it. All right,
And
go ahead.
what I would say is lecanemab is an investigational treatment as of right now. And what's exciting about that particular investigational treatment is that very recently top-line results have been shared from an ongoing trial indicating that that it's met key primary endpoints. That meaning that it has been shown to reduce clinical decline in individuals with mild cognitive impairment. So as Dr. Kremen alluded to before, which is extremely exciting. And what this tells us is that individuals that are already symptomatic, we may be identifying a treatment that has the potential to reduce the progression or delay the progression of the disease. Those results are still pending release. They will be released very soon at a formal conference the end of November. But what that means for us and other studies is that this particular drug is being utilized and evaluated in other contexts. So it's being investigated in the preclinical space. So individuals that don't yet have symptoms. In the study that I mentioned before, the AHEAD study, which is a prevention trial, if you would, that aims to prevent Alzheimer's disease, it's being evaluated there. And this poses an exciting opportunity, because this could mean that if this treatment serves the purpose that it is intended to serve, that it might be beneficial at different stages of the disease. And it might provide us an opportunity to potentially treat Alzheimer's further down the line. So it is a cause for a lot of excitement, cautious optimism as well, as we've been here before. But I think it's just a testament to where we are and where we're going, and that we're getting closer to identifying avenues for solutions for individuals that are suffering and that may be at risk for suffering. And then I think on the plasma, and I don't know if Dr. Shah wants to share more on that, but on the plasma, I think that ties very much with what Dr. Winden shared before. When we talk about these plasma biomarkers, we're looking at those proteins in blood. So the big shift has come from the way to identify whether these proteins were in your brain was to put you through a PET scan. And the advance has been that now we don't have to put you through a PET scan. We're moving in the direction of being able to draw simple blood tests and determining whether someone has high levels of these proteins in their system. And that gives us a clue as to the risk, if you would. Again, so much that needs to be determined, but allows us to kind of compare those values with the measures that have been gold standard for many years in the space. Dr. Shah, I'm sorry.
Yeah, thank you. No, of course. Wonderful. So I'll just add, just taking a step back, when Dr. Winden mentioned earlier, the two proteins that we see in Alzheimer's disease are amyloid and tau. And so what lecanemab is a monoclonal antibody that binds to amyloid to get rid of it. And what we have not known is whether or not giving a drug to reduce amyloid actually changes the disease course. Because amyloid is the first protein to deposit in the brain 15 to 20 years before we have even memory symptoms, that has been the one that has been targeted in most of these clinical trials. And really the source of what we say that target in another drug that was approved last year, aducanumab. And so what we didn't find with aducanumab, there's a lot of controversy. Yes, it removed amyloid, but did it actually change that functional independence? What I had said earlier about what we diagnose as dementia, that independence of shopping, cooking, taking your medications, that sort of thing. What was promising about lecanemab is that the clinical trial did show that there was less decline, not improvement, but less decline over time compared to the placebo in this, whereas the aducanumab drug last year had 2 trials. One showed that, the other one didn't. So what do we do with that information? What's exciting about lecanemab is that other measures of independence, other measures of cognition also had less of a decline over time compared to the placebo. What I'd be curious to know when we see the more results come out in the upcoming conference is about side effects and benefits in different patient populations. So what we usually do is treat Alzheimer's disease like it's one disease. And Lauren mentioned this earlier, it's not really uniform. We have the young patient, the older patient. Did some group benefit better? Did some group not? Are there some groups that are more likely to have side effects? So what we said earlier about this ApoE4 gene, that gene tends to cause a greater risk in a side effect with brain edema and brain hemorrhage. And that sounds scary, and it is. And so in the aducanumab drug, it was about 41% of people who had that high dose. It's about 21% in the lecanemab. But is it more in women? Is it more in ApoE4 carriers? All of that stuff we have yet to find out. Although we're very excited, we have to see a little bit more cautious optimism. Will the FDA approve it? Will insurance cover it? And that will be the big thing, because these are costly. It's an infusion where you have to go to an infusion center. And I think one other question that you had mentioned, Lauren, was what other drugs are on the horizon. So besides amyloid antibodies, we're thinking about tau antibodies, like or tau sort of manipulators. So that's the other protein that builds up. And is there a process that kind of starts the whole thing, like inflammatory signals? We're looking at that. We're looking at inflammation. We're looking at vascular risk factors. There's so many other factors here that might be at play, and maybe it's a cocktail. Like we had seen with HIV, maybe we end up giving people more individualized treatments for the individual based on their demographics and genetics, et cetera.
Fascinating. So many questions, yet I feel like we're further along than we have been in a long time. So I feel like there's also a lot of hope there. So that's great. Thank you for that. Dr. Winden, actually, this was just touched on. How can all this become affordable? How can some of these therapies, for everyone who's facing this, treatments that could exceed $10,000, $20,000, $50,000 per year, how does someone approach, navigating through this?
Sure. So the $1 million question, no pun intended, is who's paying for this, right? So we have these novel therapies that are coming out, but how are they actually going to be made affordable? Many of us have recollection of what occurred in June 2021 when aducanumab was approved, and the initial sticker price was listed at $56,000. Again, $56,000. I know I fell out of my seat also when I first saw the sticker price. That was subsequently reduced or halved to about $28,000 in December of 2021, but that's still an astronomical amount of money. And so where we stand currently in terms of coverage is interesting. It's a rapidly kind of dynamic, a rapidly evolving question and field. If you look at Medicare coverage, so the vast majority of us who care for loved ones or have Alzheimer's ourselves, we're actually going to be paying through Medicare. So Medicare rendered a decision earlier this year to cover aducanumab and other monoclonal anti-amyloid therapies under what is called a CED, or a coverage with evidence development. That basically means that they're linking paying for a medication to participation in an approved clinical trial or study. And so they have this CED currently for the entire class of anti-amyloid monoclonal antibodies. This may change in the future, but that's where things stand currently. Now, obviously, there are inherent problems with this. And one of the inherent issues is access, right? If you're not part of one of these clinical trials or registry, whatever have you, you actually don't qualify for coverage of the medication. So there are a number of individuals under the current decision that actually don't have access to monoclonal amyloid therapies basically because of, they can't access a clinical trial. Other groups also. So if you look at veterans coverage, many of us are also aware that the Department of Veteran Affairs back actually last year in 2021 also said they would not cover aducanumab, the new medication that was released. That may change with, additional data coming out with regards to lecanemab, donanemab, a couple of other medications. But as it stands right now, they actually made a firm stance against covering aducanumab. And then what about private insurers? So many of us are actually familiar also with the fact that Aetna came out and said that they would cover aducanumab if very specific criteria were met. They actually came out with that decision earlier this year. And so we're in really a rapidly kind of evolving situation where obviously it's a critical part of accessing these therapies, who's going to pay for them, but it's going to change. My estimation is quite a bit, especially in the coming months as we get more data, particularly with some of the additional therapies that are going to be made potentially available.
That is rough. Does anyone have anything to add to that? I'm going to add that I think that one of the ways to change some of that is to share stories. And a lot of people that experience dementia and Alzheimer's don't share their story, and they feel a lot of the stigma that surrounds it. And I understand that. However, I think that the more we can share our stories, the more it can pressure government systems that can then help make these therapies more affordable to everyone. So, it seems tough, but I think that that is a reminder that it is so important to make sure that we all are putting out there that there is a great need to make this affordable for everyone. So, all right, we'll move on to the next. Dr. Parend, what type of exercises can be done if someone is having walking difficulties, gait and balance supported by physical therapy? How does that work when someone has dementia and their physical capabilities are starting to falter? How do you navigate that?
So I do want to answer that question, but just to add, for the clinical trials, if an institution that you're working with, isn't available if it's too far out, or you can look on clinicaltrials.gov and see if there's another place locally that would have it. I know that there's certain criteria for clinical trials, but just keep that in mind that if you can't get into the place that you want to get into, that there could be other avenues depending on the criteria that you meet. I just wanted to add that because sometimes that happens in clinic, patients ask that. But to address the exercises, so it's good to stay active. So doing some type of aerobic exercise for, on average, for about 30 minutes a day of moderate exercise 5 days a week is very helpful. So if a patient can't walk, you just sit and pedal. You get it on Amazon or order it, over from different places over the internet. Other things is working with physical therapy. So if you need to have physical therapy come to your home or go to a physical therapy location to be able to get some movement addressed. And if someone cannot move, they're bed bound, or for whatever reason they're having difficulties with movements, is having at least passive range of motion and working either with your family or even having a physical therapist come to the home to help do that, or the nursing facility. So it's important to keep moving, not only for the muscles, but also for good brain health.
Yeah, definitely. Anyone want to add on to that one? Okay, we're going to move on then. Keep going. We're going to go through. We've got so many more and so little time. So Dr. Kremen, gosh, and this one I can so relate to with, what we went through with my mom. What do you do when a patient is in denial and doesn't want to accept help? What causes outbursts, literal hallucinations, and what is mirror misidentification?
Okay. This is a lot of things all rolled into one. Okay. So sometimes people do not realize that they're having the difficulties that they're having, or sometimes they do realize it, but they, are not ready yet to really, as one could understand, really accept that. And sometimes I'm not sure when people say, my mom's in denial, what does that really mean? Does it mean she's aware, but she's not, I don't know, but I don't want to say owning up or not realizing it or admitting it, but sometimes people are actually not aware. They lose insight. And so it seems like they're not owning up to it or whatever, but they may not really realize the depth to which they're having difficulties. And that's because the frontal part of your brain that helps you be aware and have some sort of insight is starting not to work, as well as the areas of the brain that deal with short-term memory. And you can imagine that if your short-term memory doesn't work, then you're constantly living in the present. And so if you can't remember something, you may not realize that you're not remembering something you were supposed to. Your reality is you're doing just fine. So that's sort of people outside who are around the people who are starting to have problems. This can be really difficult navigating it. And so I think it just has to be done very gingerly, and to not necessarily confront somebody and say, you're really having problems and this really needs to be dealt with. That is going to probably not be the greatest thing. So it's basically trying to figure out, how do you try to get somebody some help without offending them, but really coming at it from a helpful point of view, like, in ways that, hey, can I help you do this? Or, I'm noticing that, maybe one way to do it, like if they're forgetting to take their medications, figure out a way to have dinner with somebody. I mean, I'm just going to put this out there, but you could have dinner with them every night, and then you just kind of give them the medications, and it doesn't become a battle because it just becomes something that you just do as a routine. And so we could spend a whole nother hour just talking about that. So we won't be able to keep going on that. So what causes outbursts and hallucinations? So outbursts, again, is usually because the frontal part of your brain, not only is it helping you with insight, but your frontal part of your brain also helps you with inhibition and monitoring your behavior, and also helps you with patience and understanding social rules. And so when people start to have dementia, these pathways essentially start to degenerate. And so they're just that level of control goes away. And so people just have a shorter fuse, or can't read the social situation anymore. They don't care. They become much more focused on, I want something now. And we can all have that feeling, right? Right now we could be thinking, I'm in this webinar, but I just want, I want to get up and do something else, but we're not doing it, right? Or I wish I could have some, a coffee now, but we're not going to do that. It's not what you do. But, they instead follow that very gut desire. And so those pathways to sort of control that behavior goes away. In terms of hallucinations, hallucinations can really happen when there's a breakdown along the visual pathways, anywhere from an actual eye problem, back all the way to the back of the brain, where the visual stimuli is actually processed, et cetera. So when people who have visual hallucinations, one of the first things we have them do is see an ophthalmologist to make sure that there is nothing wrong with their eye. Because if it's an eye problem, then, or something wrong with the retina, something wrong with, maybe they've had a increase in glaucoma, those things need to be addressed. Otherwise, visual hallucinations can happen just because there's damage to various parts of the brain, and the brain abhors a vacuum. So if it's not getting input, then it makes up the input itself. And so the visual part of the brain will then start making things up. And I'll leave it at that. Lastly, mirror misidentification, or otherwise known as the mirror sign. So this can be seen in people who have pretty moderate dementia, where they'll look at the mirror and they don't recognize themselves in the mirror. They actually perceive that face in the mirror to be somebody else. And that's because they're starting to have changes in the brain that with visual processing, and also a mismatch between what their memory might be of what they look like and what they see. And so between the memory problem and the visual spatial and misperception processing problem, they will start to actually have arguments with themselves in the mirror and not realize that it's them that they're talking to. So the easy solution to that is put towels over the mirrors. That way they don't have to argue against anybody.
Oh, you've just said so much. I mean, I think that, again, people who are, very familiar with this disease can relate to so much of that. And that is exactly why this is so difficult to navigate and care for people who are dealing with it. So
can I add
caregivers, you're out there getting support.
Just because what Dr. Kremen said about the patient's reality, it's not necessarily your reality. And this is a majority of when a patient has more advanced symptoms with the agitation and the difficulty with patients and families. And this is a large discussion about how do we match up what they understand and what you understand. And I think what I've done with counseling through the years with patients and families is not so much you're not going to match up. You know, if the if a patient thinks the sky is purple and you think the sky is red, you're just not going to line up. And so finding what might work for you guys as a family can often help with the outbursts, with the training and understanding of family members. And if you say, for example, they don't want to accept help, I might say to the patient, you know, exercise is good for your brain. And they might say, yeah, I want to exercise. So we'll hire a personal trainer for you as opposed, or a personal assistant to support you, as opposed to a caregiver or someone who's going to feed you your medications. So finding those battles and the ways that may work for your family member or loved one, it's no one right answer. So just thought I'd add that if in case it helps anyone.
Yeah. And it is hard. It is not easy. And acknowledging that, I think, is key. So again, it's a real journey. Okay, back to sort of a little bit more prevention side of things, Dr. Melina Henry. You know, we kind of touched on prevention a bit. Besides exercise, diet, how do we avoid this? Is it avoidable? How do we at least reduce our risk?
We are hoping that we can make it avoidable. But can we reduce our risk? And I think that the answer is yes. And I think we're finding more and more and more evidence to indicate that that is the case. Exercise is, as mentioned before, is one of those key pillars of brain health, as is nutritional eating. And there's a number of different types of recommendations as far as what individuals should consume for that healthy brain. I think the other things that I would add that often don't get discussed because we don't think about it when we're awake is sleeping and getting good night's rest. And it is very, very, very tied to your brain health over the years. In addition to that, staying connected, being in support networks, being involved in community activities. I'd love to talk about my mother-in-law in these situations because she belongs to this group of ladies that play volleyball and they do it on a chair, but she's connected and she's involved and they know each other. And in addition to that, just challenging your brain. We think that schooling is the big part of doing that, but maintaining that engagement and just challenging your brain to learn new things, to read new things. Those are often noted as things that help us always live a much more wholesome life, but can keep our brains much more healthy. Another thing that is often talked about, but we don't necessarily bring to the forefront, is that stress management. These are key determinants of your health. And along with that, just managing your chronic conditions. Some of us can't get away from the fact that we may be diabetics or have hypertension, and some of that may be family history. But being able to manage those with what's available to manage can also help reduce your risk for developing the dementias or other progressive neurodegenerative disorders in the future.
Yeah. Yeah. I love that there's action items with that go with prevention, and it feels like you can really, you know, make some steps and make some changes. Does anyone have anything I want to add to that?
I'll add one more thing and I'll let others, but one more thing to add is if there are registries or clinical trials available and you are concerned about risk, you know, particularly prevention trials, this is a great time to be involved, to be aware, and to get a little bit more understanding personally, but also doing the part as so that we can continue to fight this.
Yeah, definitely. All right, we're coming down to the end here. I'm actually gonna we're gonna go to Dr. Winden. Thoughts on Prevagen or other supplements? Supplements are, God, I mean, again, we could have 3 hours for each of these questions, I feel like. But you know, as the clock is ticking, give us your thoughts.
Sure. A lot to unpack, so I'll try to speak quickly. So when we think about Prevagen specifically, so Prevagen is essentially, its active ingredient is a calcium binding protein that's found in jellyfish. The company basically makes a synthetic version of it. Quite expensive, anywhere from $40, I think, a month to $90 for the extra strength. And so, you're looking at spending anywhere from $500 to in excess of $1,000 per year for a supplement. There is no randomized clinical trial to date that has been done by an independent group that has clearly demonstrated Prevagen either reduces the risk of dementia, slows cognitive decline. A lot of the advertisements that are made by the company itself in terms of labeling and whatnot, you have to take a little bit with a grain of salt. And so, unfortunately, in the world of supplements in general for brain health, we're dealing with oftentimes conditions like Alzheimer's where they're degenerative. They aren't going to get better on their own. And so folks are willing to really grasp at anything. You're willing to buy kind of anything over the counter that you think might make a difference. The problem with that is that, again, the financial cost of it, oftentimes you're spending a significant amount of money on something that's not going to benefit you. The other thing you have to be very careful about with supplements in general is that they sometimes can contain things you don't actually want to be taking. They can interact with other medications. They can actually cause quite a bit of side effects and quite a bit of harm. So you have to be very careful about whatever it is you're taking over the counter for the purposes of brain health. And you're actually much better off using the $500 you would spend on Prevagen and joining a gym or taking the trip that you always want to take or buying some books. A lot of better ways, I would say, to save the money and spend it.
Love that answer. I've never heard someone say it quite like that. And I think that's a really smart way to say it. So I'm going to remember that one. Oh, and with that, here's our lovely hostess with the mostess, Susan Evans. I will turn it over to you.
I just got off my exercise bike, so I'm so glad that I got to hear all that good stuff about prevention. But most of you know that my father was diagnosed with Alzheimer's. Actually, Dr. Shaw was his doctor at Stanford 10 years ago, and I am so encouraged. I'm just so encouraged about the advancements you've made. I'm encouraged we're taking the stigma away. I'm encouraged that everyone's doing these educational events. I'm so encouraged by the prevention and what we can do together as a community to help everyone. It's a dreadful, dreadful disease. And I agree with what Lauren said. We have to share the stories. We have to be heard. We have to support the caregivers. And you're just all doing that. So I just cannot thank you enough. And I cannot thank our audience enough. You all will be receiving a copy of today's webinar to share with friends and family, and links to all that great information that we just received. The chat was going crazy with, I need to know this, I need to know what Dr. Prawn said about videos and about trials, and we will include all of that stuff. But just once again, thank you. Good night, good afternoon, no matter where you are. And thank you to these wonderful guests and to all of our physicians and to Lauren Miller Rogen for moderating. And everybody have a good night and be safe. Thank you. Bravo.
Thank you.